So yeah, many thanks for inviting me to give this presentation on targeting KIT in advanced systemic mastocytosis. So I think in the last 5 to 10 years, also the MPN field has really become aware of systemic mastocytosis. 10 years ago, most of you may not have seen, patients, but now with new advancements that have been made in molecular genetics, we identify more and more the KIT D816V mutation in a variety of myeloid neoplasms, such as CMML or chronic eosinophilic leukemia, and even in AML. So mastocytosis by itself, advanced systemic mastocytosis, has three subtypes. This is aggressive systemic mastocytosis, which is basically defined by organ damage, defined as C findings. This is anemia, thrombocytopenia, liver dysfunction. Then we have mast cell leukemia. Mast cell leukemia is a disease which can really look like acute myeloid leukemia with 90% bone marrow infiltration by immature mast cells, and very important SM-AHN. And this is about 60 to 70% of cases. And this means that patients do not only carry the KIT D816V mutation, but also other somatic mutations, and the frequency and the overall pattern of these other somatic mutations is, for example, very similar to that what we see in myelofibrosis. So basically, the disease is aggressive, survival is poor. Usually less than 3 to 4 years. For mast cell leukemia, even less. So in many series, less than 1 year. As I already mentioned, KIT is the central driver. It is present in 95% of patients, so very similar to BCR-ABL in CML or JAK2V6NF in polycythemia vera. I've already mentioned the additional somatic mutations, and by now we have 2 approved KIT inhibitors. So midostaurin, which is a more broad inhibitor, which the first clinical trial started in 2009, and the drug was approved in 2017 in Europe. And then avapritinib. So this is a specific KIT inhibitor. It is highly selective for KIT D816V. It has a much higher potency. So there are also 2 new KIT inhibitors. This is bezuclastinib and elenestinib. I just wanted to mention that. So this is not part of today's presentation. So now in the next slides, I would solely focus on avapritinib, because this is clearly the most effective and the most recent approved KIT inhibitor. And there are 2 clinical trials. The Explorer trial, a phase 1 international multi-center trial with 69 evaluable patients. Primary endpoint, maximum tolerated dose, recommended phase 2 dose, secondary endpoints, overall response rate, changes in bone marrow mast cell burden, serum tryptase, which is a very nice and very reliable marker in the serum, and KIT D816V allele burden. And then the phase 2 trial, Pathfinder, another international multi-center trial with 62 patients included, 32 evaluable patients. The primary endpoint was the overall response rate, and secondary endpoints very similar to that, what I've already said from Explorer. And then we did not only see the individual presentation of these studies, but there were also pooled analysis, because the disease is overall very rare, and we need as many patients as possible to get reasonable and reliable results. And here you can see that key parameters for analysis is, for example, the bone marrow mast cell infiltration, the serum tryptase, which I already mentioned, the KIT D816V allele burden, then the overall response rate, also meaning beside mast cell burden and serum tryptase reduction, also normalization of cytopenias, overall survival, and of course safety is also a very important point. And the Pathfinder trial, we just recently were able to publish the 4-year follow-up data of this study, meanwhile with a median follow-up of 49 months. So this is the clinical response to avapritinib. And as I just said, the clinical picture may frequently look like advanced CMML or even acute myeloid leukemia, with 90% mast cell infiltration. I already mentioned to you the very poor survival of these patients. And now here you can see the response rates. And this is really very impressive. So an overall response rate of 70%, complete responses in about 30% of patients who are treatment naive, partial responses also in 30% of patients. But what you can also see that even previously treated patients had, these responses. So complete responses seen in 20% of patients and partial responses in 45% of patients. And the response emerges quickly. So we have a median time to response of only 2 months. And we have a median time to complete response and complete response with incomplete hematologic remission also of 9 months. So you can see fairly quickly whether the patient responds to the drug. So the responses overall, they were not only rapid, but they are deep, as you can see from the overall response rate of 70%, and they deepened over time. So the drug, I will say later also, of course, something about safety. So many patients remain on the drug, and the median duration of response is 38 months. So this is what I already mentioned. So the depth of response, and fortunately, we do not only have bone marrow mast cell burden, serum tryptase, and hematologic parameters like anemia and thrombocytopenia. We also have the KIT D816V mutation and its allele burden, which is the mutation which is present in more than 90% of patients. And here you can see the partial response with more than 50% reduction of the allele burden in 80% of patients in Explorer, in 60% in Pathfinder. And you can see that there were even about 1/3 of patients achieving unmeasurable KIT D816V, meaning complete molecular remission. And on the right side, you can see that usually these responses of the KIT D816V allele burden is associated also with the responses which I mentioned in one of the previous slides. So when you see a patient with a complete response or with a complete response with incomplete hematologic recovery, you can expect in more than 50% of patients that they will achieve a deep or even complete molecular response. So greater reductions in the allele burden were associated with deeper responses. So and now the data, the 4-year follow-up data, which are just right now being published in Blood Advances. And you can see what a summary of what I've already said in the previous slides. So a very high overall response rates, slightly better in patients being treatment naive. But from my view, even more important, or if equally important, that patients also with prior systemic therapy also can achieve, high response rates with about 20% of patients achieving complete remissions, and the response occurs quickly. So, and the efficacy of avapritinib extended across all also defined risk groups by the MAS score and independently of the subtype. So the durable responses aligned with substantial reductions in all markers of disease burden, like mast cell bone marrow infiltration, tryptase, allele burden, and the measures of organ infiltration, organ damage, such as anemia and thrombocytopenia. And as I said, the responses are quick, the responses are deep, the responses are durable, and they are, of course, they look much better than those which were obtained with midostaurin. And therefore, and these are the survival curves. And here you can see something very important. So you can see 4 survival curves. So the blue one is the curve for advanced for aggressive systemic mastocytosis, and the green one is the curve for mast cell leukemia. And why do they look better than the other 2 survival curves? So this is the impact of additional somatic mutations. So the blue and the green curve, they actually represent what we nowadays say about pure mast cell disease. Pure mast cell disease or pure mast cell leukemia, and the survival is better than for patients who have additional somatic mutations featuring in this systemic mastocytosis with associated hematologic neoplasm, most frequently CMML. And then on the right side, on the right bottom, you can see the overall survival by prior treatment. Please remember what I said before. The median survival prior to introduction of midostaurin, less than 2 to 3 years. The overall survival, including a high proportion of patients with mast cell leukemia, then 29 months. And now you can see the overall survival for patients, all patients 62 months, for treatment-naive patients not yet reached, and even for patients with 1 prior systemic therapy, 60 months. So, of course, we also need to talk about safety. So the drug, it is an oral drug once a day, 200 milligrams starting dose. And the safety, the major concerns are about edema. So periorbital and peripheral edema, which we expect in more than 50% of patients. They can be managed with dose modifications or with dose reduction, but not in all the patients. But this is usually a side effect which is tolerated by the patients. And I have only seen very, very few patients who stopped avapritinib because of edema when they otherwise had a good response. Then, of course, we have hematologic adverse effects such as thrombocytopenia and anemia, usually also manageable with dose modification. But the thrombocytopenia, we have to say that thrombocytopenia can be dangerous for brain bleedings. And after safety measurements, looking into that, we should not start avapritinib with platelets less than 50,000, or when platelets occur of less than 50,000, that we should stop the drug. And then the rate of the intracranial bleedings, which we saw in Explorer, were substantially reduced in other studies. So overall, edema and sometimes memory effects also manageable by dose modification and the hematologic side effects. And so the starting dose is usually 200 milligrams, and because of the side effects and according to response, we may reduce the dose over time. And in the study, in the Pathfinder study, the median daily dose was about 100 milligrams. And then finally, we also performed retrospective comparison of survival. I mean, there will never be a randomized trial because the disease is so rare. And here you can see the survival curve in red for avapritinib versus best available treatment. So this was an international cohort. So the overall survival was significantly better with avapritinib versus BAT with a hazard ratio of approximately 0.5. And in the next slide, you can see that in a subsequent analysis, we split the BAT group for patients which had been treated with midostaurin or with cladribine. So you see the superiority of avapritinib versus midostaurin, and even more versus cladribine. So, and these are the future directions in KIT inhibition. Currently we have in clinical trials 2 new drugs, so bezuclastinib and elenestinib, both also very highly potent and selective inhibitors. Particularly bezuclastinib has minimal brain penetration, and there is a phase 2 APEX trial, and this data will be presented at this year's EHA meeting in an oral presentation. And on the right side, you can see what was reported in 2025 in December. So also over response rate of about 60%, over response rate per PPR criteria 80%. And it is very similar to what I said before about serum tryptase, mast cell burden, and also KIT D816V allele burden, what I said about avapritinib. Overall, very well tolerated, and only 15% of patients required dose reductions. And elenestinib is a drug which was in clinical trials in advanced systemic mastocytosis, but these trials were paused, and it is currently under investigation in indolent systemic mastocytosis. So I think now the next slide is my last slide. This is just the summary, and I would just like to keep it as it is, and maybe we keep it on the screen and everybody can read it. I mean, what I've already said. So additional somatic mutations are important. SMA again, we see fantastic responses, and I think that this disease is a very, very good model disease of what we can probably also expect in myelofibrosis. And therefore, I'm very happy that I was invited today, because I may foresee that we see very similar things in myelofibrosis, whether patients have JAK2 V6NF alone, or whether there are also additional somatic mutations. And finally, of course, in the future, we also have to talk about the role and timing of allogeneic stem cell transplantation as the only option to cure the patients. Thank you for your attention.
Thank you very much, Andreas. Now it's open for the discussion. Who wants to answer the first question, maybe, about balancing between mast cell disease and the associated hematological neoplasm? I think it's quite easy when one of the components is much more prominent for the patient in terms of disease burden or symptoms. But Stefan, you want to comment on this? Yeah.
Thank you, Andreas. This is quite exciting again and again to see this. I'm always wondering what is different between these pure mast cell neoplasms and maybe primary myelofibrosis. In both cases, you have a tyrosine kinase inhibitor, and you have just a tyrosine kinase, a single nucleotide exchange and single amino acid exchange. Could you tell us why is this so effective in mastocytosis? Is it really the type of cell that is very vulnerable to this to KIT signaling, and this is different for JAK2 in MF, or how do you explain this really excellent molecular response here?
Well, I mean, this is a very difficult question, and I may not be able to answer that because I do not exactly know, what are the biochemical properties of these mutations and the cells. But what we know is that, I mean, looking at the potential, I mean, at a real difference between JAK and KIT inhibitors is that these new KIT inhibitors, they are said to be highly selective. I mean, really active at nanomolar concentrations. They have shown, activity in cells, in mice, and then in human beings. And I think that the JAK inhibitors have not yet reached the same level. I mean, we are now talking also about selective JAK inhibitors, and we may have to see. I think that one of the important differences probably now, for example, when I that in myelofibrosis, there's probably one of the problems is also myelofibrosis. It's probably not only the efficacy of the drug towards the cells, but it will also be a question to which extent myelofibrosis is reversible, even when I have, something like a hematologic or molecular response. I mean, we can only see that, with the first very effective drugs, with the very JAK inhibitors, really also doing something like partial molecular response or even complete molecular response. And of course, I'm also very much looking forward what happens to the additional somatic mutations. And this is maybe, I think for the group here, very interesting also observation that we see patients in which the allele burden of additional somatic mutations remains stable, even with excellent molecular remission. So hypothesizing that there are different clones, I mean, we already know that there are different clones in this disease, but we also see a decline of the additional somatic mutations in some of the patients. So meaning that there are obviously cells who are positive for KIT and additional somatic mutations and who still show a response on the KIT inhibitor. And this is something I think we also need for myelofibrosis. So that, the additional somatic mutations is not conferring primary resistance to the check inhibitor in these cells. But basically, I mean, the cells are obviously a little bit different, but at the end, I mean, with the AHN, we are also targeting monocytes, neutrophils. I mean, more or less the same cells like in classical MPN.
Mm.
Sorry for a long answer, but the question was
difficult task.
Oh, very helpful. Thank you. Are there any other comments about the second point in particular? Are we now in our way of treatment-free remissions in this disease with these type of drugs? Andreas?
Oh, yes. I mean, this is a very, very important question. And I have to say, I mean, nothing has yet been published but of course, in some of our patients, we had to stop the drug, for example, because of comorbidity, heart problems, valve replacement or whatever. And we have already observed also in patients on midostaurin, in some of the patients, that the remissions remain stable. I mean, not in every patient, but it will be the same like for all other hematologic neoplasms. In a proportion of patients, we saw, let me say, stable remissions of KIT D816V. I mean, this is relatively very easy to monitor, and also tryptase. The problem is always the AHN. I mean, here we really have to deal with two patients, and the problem can become, so for example, that CHEK2V6NF itself is the fifth most frequent mutation in systemic mastocytosis. And in some of the patients, we see that we have this very nice partial or even complete molecular response. And at the same time, we have an increase of CHEK2V6NF. So as if the CHEK2V6NF clones just uses the space that was created by the molecular response. So, I mean, this is another, I think, really very important point why this disease can really be a good copy for a model disease of the competing clones, and what can happen when you target very successfully one of the clones. You may really give rise to the clone with the mutation. I mean, something which we already saw or had already seen in CML with T359 mutations. I mean, they already exist at diagnosis, and they just get the chance to emerge with the remission of the, let me say, regular CML clone.
Okay, thank you. Just from a practical point of view, we were frightened by the intracranial bleedings at the beginning with the first reports. To now it's quite manageable now that we are aware of this potential complication, looking for thrombocytopenia. Is there any particular caution to be safe on the safe side?
Yes, I mean, this is what we are doing. So we are usually not starting the drug when platelets are less than 50,000, and we are stopping the drug when platelets are less than 50,000. I mean, I have to be honest, we have not completely strictly followed this rule. I mean, we do not stop because of 45,000 platelets. And of course, it also depends on age and comorbidity of the patients and, about the disease phenotype. I mean, in some of the patients, you have to go through some time of reduced platelets, and then with response, they go to higher levels. And I have to say, just from my very personal experience, we have experience as a single center with more than 40 patients treated with avapritinib, and we have only seen one clinically asymptomatic subdural, very small hematoma, and not a single really heavy bleeding, and even causing not at all causing death. But we are careful, and we really want to see our patients, I mean, the older they are, the higher the comorbidity and the worse the blood counts. We really try to see our patients as often as possible and often as needed, because of this management. Because also in this disease, the higher the dose, the higher the efficacy, So it needs a good compromise between the dose and the side effects.